is you have to identify what is this. So this is a specimen of the gall bladder. Number one. Then he can ask you what are the parts of the gall bladder. The parts of the gall bladder are the fundus, the body, neck, and cystic duct, of course, which is ligated here. You can see it is involved. And what do you see? This has been cut open in a diamond-shaped incision, and if you go inside, there is a stone inside. So this is a gall bladder which has a stone inside, and this is called cholelithiasis. Okay? This is called cholelithiasis. Complications of the gallstones are acute cholecystitis. When there is a pain, right hypochondrium epigastrum, there will be vomiting. Okay? And patient may have, Murphy's sign may be positive. That means patient will be having tenderness in right hypochondrium. When your index finger strikes the gallbladder during inspiration, and there will be a sudden catch in breathing. That is Murphy's sign, which is similar to almost Moynihan's sign. One is done in sitting position, other is done in lying down position. So complications of the gallstone, acute cholecystitis, chronic cholecystitis, there may be pus inside, there may be mucocele of the gallbladder, not that is you are talking about clinical features. There will be empyema of the gallbladder, pus in the gallbladder, and mucocele of the gallbladder. And what else? Merides syndrome. Merides syndrome compresses the CVD, and patient may have obstructive jaundice. Then it may perforate. It's called gallstone ileus. The gallstone may perforate from its wall and enter into the duodenum, and it may lodge 60 centimeter above the ileocecal junction. And there is a triad of identification of this by radiology, and that is you will find pneumobilia, gas in the common bile duct, biliary tree. Number two, you will find abnormal mineral shadow in X-ray in the ileum. Abnormal mineral shadow, number one. Okay? Number two will be pneumobilia. And number three, what it will be? Obstruction. Stone, jitna niche jayega, it will keep on gathering the layer of intestinal contents. It causes intestinal obstruction. So three things will be there. I think if I am not wrong, this is called regular stripe. I may be forgetting, please check back. Regular stripe. Anybody is having net here? Regular stripe. So there is intestinal obstruction, there is an abnormal mineral shadow in the intestine, 60 centimeter proximal to ileocecal junction, which you cannot make out in X-ray, and pneumobilia. Take, samajh aa gayi? And what is the pathology? The pathology of the gallstone disease, if there is a cholecystitis, there will be, the gallbladder may be shrunken, thickened, wall may be thick, it is fibrotic, okay, and inflammatory cells will be there. So therefore, now again, continuing with the complication, the patient may have hemorrhagic syndrome, gallstone ileus, that means perforation of the gallstone into the duodenum, and there it goes down into the ileum and causes intestinal obstruction. Then of course it can get transport, gallbladder may have ultimately carcinoma, cancer of the gallbladder. There are two varieties, maybe squamous cell carcinoma and adenocarcinoma. And what is the life-threatening complication of gallstones? Anybody can tell me? Acute pancreatitis, that is reflux of biliary sludge into the pancreatic duct. Okay, possibly, number one. And secondly, the small stone, larger stones cannot migrate into cystic, CBD through the cystic duct, because cystic duct is narrow. Cystic duct may be up to 2.5 centimeter long and about 1 mm to 2 mm wide. But if cystic duct is wider, the stone inside the gallbladder will migrate into the common bile duct, and patient will get obstructive jaundice. And this condition is called choledocholithiasis. Choledocholithiasis. What is it called? Choledocholithiasis. And once there is a choledocholithiasis, you have to remove the stone from the CVD, which is called choledocholithotomy. It's called choledocholithotomy, either used by ERCP, endoscopic retrograde cholangiopancreatography, but then at the same sitting you have to remove the gallstone or gallbladder also. Okay, if you remove the stone from CVD, This is called qualitatively taught me either open method or by ERCP. You have to remove the gallstone in the same hospitalization. Person who has got cholelithiasis, the stone has migrated into the CBD. You remove the stone by ERCP, endoscopic retrograde cholangiopancreatography. Of course, you can do, this contrast studies also, but you can remove the stone. And before the patient goes to home, you must remove the gallbladder also. You get my point? Then there are primary CBD stones, there are the secondary CBD stones. You see that? The stones may be, black colored because of hemolytic disorder, hereditary spherocytosis, hemolytic anemia of all kind. You will find black stones, but brown stones in the CBD are due to infection. You have done the cholecystectomy and you find the CBD stones later on. So if up to 1 year, they are attributed to the surgery. Retained calculi, they are called retained calculi. They are primary CBD calculi which are formed in the CBD, because of infection. And what is the infection? The infection is due to organs like E. coli, staphylococci, and all kind of anaerobes and things like that. Obstructive jaundice can also occur due to periampullary carcinoma, but in that event, the gallbladder will be palpable. So, the definition of Courvoisier's law is, what is the definition of Courvoisier's law? That in a jaundice patient, if the gallbladder is palpable, it is not due to CBD calculi.
Gallbladder is inflammation and fibrosed.
So the gallbladder will be fibrosed due to previous infection. All right. And what else? What can be the problem? What other problems can come up? The gallbladder can perforate, and perforation of the gallbladder because of the obstruction of the neck can occur because of the stone, and the perforation generally will occur at what place? It will occur at the fundus of the gallbladder, because why? That is the area which is most distant from circulation. By the time the blood circulation, arterial circulation through the cystic artery. Cystic artery is a branch of right hepatic artery, which is a continuation of the hepatic artery which comes from the celiac axis. The celiac axis divides into left gastric, hepatic artery, and splenic artery. And hepatic artery divides into common hepatic artery, the gastroduodenal artery, and the right gastroepiploic artery. So cystic artery is a branch of hepatic artery, and therefore the fundus of the gallbladder is the most distant part from the blood supply. So therefore, if the perforation has to occur, it occurs at the fundus of the gallbladder, which result in bile peritonitis. The patient will be in shock. That means person will be having bile peritonitis, and sometimes there may be local perforation, means at the neck of the gallbladder will cause localized peritonitis. These are the complications of the gallstones, sufficient complications. So therefore, gallstones may be asymptomatic, but you have to advise the patient, look, if the person comes to know that he has gallstones, he will be convinced ultimately that these stones should be removed. If you recite all these complications, at acute cholecystitis and chronic cholecystitis and things like that, it can become cancer. So almost all of them will get prepared one day for surgery. Okay? Otherwise, there are many people who live with asymptomatic gallstones till old age. They don't know they have gallstones. But now the gallstone surgery is being done increasingly, just because the patient awareness. Secondly, now we have ultrasound and investigations like that. But previously we had no investigation. These investigations like CT, ERCP and ultrasound have come up in just, last 30 to 40 years. Otherwise, it is very difficult to diagnose cholelithiasis. There is no investigation available to us to detect gallstones except, oral cholecystography, and which you have never heard of, I am sure. We have stopped teaching about oral cholecystography now because we have better investigation, unless in a remote part where there is no ultrasound machine and things like that. All right. So I think, shall we call it a day or shall we go ahead? Band kare kya? All